Welcome, everybody. This afternoon session is really going to focus on the data, but one of the things that we wanted to talk a little bit about is how our new president-elect is going to change the way that we currently look at our healthcare benefits strategy and healthcare benefits offering through an employer-sponsored plan. So President-elect Trump has stated several times throughout his campaign that he wants to repeal and replace ACA in the first 100 days of his administration. So that is a very aggressive stance. He's basically said there are pieces of it when asked that he might consider retaining, and those are the more popular items. So I kind of chuckled a little bit when I wrote it maybe should be called refined and rebranded versus repealed and replaced. But we will, we will see what pieces he retains. There's been a lot of interviews lately with the president-elect on what his administration will look like. We were looking at the makeup of the Senate and the House, and the Republicans retained control of the Senate. They retained control of the House, but they don't have enough seats to block a filibuster if the Democrats wanted to filibuster legislation making its way to the Senate. So a full repeal and replace may get complicated. Additionally, if you look at the number of people in Congress that are up for re-election in 2018, it may be that some of them, depending on what he wants to change and what he wants to repeal, if they are popular items, there may be Republicans that won't support the repeal process as well. It's said that he has tapped the top spot of the Secretary of Labor to Victoria Limpnick, and she is she's very employer friendly. So that's something that would be a welcome for us on the employer side, managing benefits. So that's some good news if she indeed gets the nomination. And then it's all bets are off for the Secretary of Health and Human Services. So this is a big slot for us. This is where legislation really gets rolled out on the employer side. Rich Bagger was the former head of a New Jersey Blue Cross Blue Shield plan. He was also a former Pfizer executive, so he certainly has a lot of experience. Rick Scott, we know, is the governor of Florida. And he was also the former CEO of Tenet Health Systems, which is a very large hospital system. Ben Carson, who was a Republican candidate for president, also a neurosurgeon, was thought to be somebody of interest for this position, but the news today was leaning towards that he is out and maybe being vetted for potentially the Surgeon General position in the new administration. And then, of course, we have Newt Gingrich, who is the former Secretary of the House and a very outspoken individual, so that would be interesting. One of the things that people are pontificating about in the new administration is who's going to lead this charge for President-elect Trump. And I think most people are thinking that Mike Pence, the vice president, would probably take this on. He has some experience in the healthcare development strategy area and did, in his state of Indiana, created a consistent model with what they're talking about in the new administration. So jumping quickly into kind of what the overview or the likely impact of the changes, renewed attempts in the first 100 days to repeal ACA. They're definitely talking about phasing out the exchanges, and instead of the state-run exchanges or the federally run exchanges, replacing those with a free marketplace offering of individual coverage with tax credits, where people could go out and purchase their own coverage with the tax credit. He certainly has talked a lot about advancing the consumer-directed health plans. That would be, obviously a very welcomed opportunity for us as employers because they're significant right now. Prevalence of the consumer-directed health plans. With 2017, 84% of large employers are going to be offering consumer-directed health plans as an option, and 35% of large employers will only offer a consumer-directed health plan in 2017. He's significantly talked about expanding the HSA opportunities, coupling with those consumer-directed health plans, and some of those are very exciting. So just to kind of go down his proposed list of changes to HSAs, so the excise tax is on the chopping block, and we're hopeful that the excise tax goes away altogether. But if they retain the excise tax and they leave that in place, because the excise tax represents a significant spend for healthcare reform. The Cadillac tax was to generate $79 billion in the first 6 years. So eliminating that would make the tax credit part of offering individuals the vouchers to buy their own insurance. That would make that a lot more difficult to pay for. So they're talking about taking that excise tax and either raising the threshold, or one of the things Trump has said is that with the excise tax, he's going to discount or not count the HSA contribution. So that'll be excluded from that tax calculation, which would be a huge win for us as employers. He's talked about broadening the use of pharmacy with the HSAs, permitting the use of the HSA accounts for over-the-counter medications, permitting the use of these HSAs for fitness and nutrition expenses. And this one's a huge one, permitting HSAs for the payment of health care premiums, so insurance premiums, people potentially being able to use these HSA accounts to pay for their insurance if they leave an employer and have to go out on their own. Raising contribution amounts for the HSAs, that would be a huge tax benefit for everyone. He's talked about permitting standalone HRAs. And then the final huge one, which I really was very interested in, is he is talking about permitting HSAs to become part of an estate, so that if somebody has an HSA with a large balance and they pass, they die, that HSA would go into the estate but not subject to the death tax. So those are all pretty significant changes that he's proposing, and things that we will be watching very carefully because they're definitely going to affect how we build our strategies on the employer benefit side. The direction of Medicare is pretty much unknown at this time because he hasn't talked about it a lot, although we all know with Medicare something needs to be done to shore up the financial aspect of offering Medicare with the baby boomers entering that realm over the 10-year period, which we're about 2 or 3 years into. He has talked a lot about payment and delivery reforms, and some changes that are likely are more transparency, which again is significant for us on the employer side because all transparency on cost and quality will definitely help us manage our expenditures and help our employees, especially those in consumer-directed health plans, really use their funds most wisely. And then, of course, he has talked about adopting expanded maternity leave and child care benefits, which on the disability side of the house we need to watch very carefully. So just to kind of recap, the free market solutions are proposed instead of the state-run or federally government-run exchanges. He's talked about opening the doors to carriers for across the state line to create competition and drive down costs. And here's some of my personal thoughts on that one. If you just look at the state of Pennsylvania and the state of New Jersey insurance is more expensive than Pennsylvania. So I worry that it actually might not drive the cost down. It might cost more if people are crossing state lines to get insurance in a less expensive state. So we'll have to see how that plays out and how he is going to allow those insurance companies to offer those insurance plans across state lines. That might be one of those unforeseen consequences I'm imagining in some states. In some states it'll work real well. In some states it could actually raise the cost. Pharmacy changes, this was exciting. He talked a lot about removing barriers for new drug entry to market and opening up international options for pharmaceuticals. Again, I think there's some unforeseen consequences there that are a little bit worrisome. If the drugs are coming in from another country and not necessarily going through the clinical steps that we have in the United States for something to be cleared as safe. So those are some things to think about. While it might be less expensive, it might open some other challenges for us on the quality side. And of course, he is going to try to push the FDA for fast-tracking approvals of biosimilars. So remember, the biosimilars are the generic specialty drugs. And again, that would help us on the cost side for sure. And then for many of us who have gray hair over the ACA tracking and reporting over the last year, there's talk that they're eliminating all of those reporting requirements and that those will go away in the future. So I just sit and I think, how many millions of dollars did we spend on trying to meet those requirements, and now they're going away. So I guess it's a good thing, but it's aggravating to think about that for sure. And then he's talked a lot about retaining some of the popular pieces of the ACA, including no pre-existing condition, coverage for dependents up to age 26, guaranteed issued coverage, guaranteed renewed coverage, and a ban on the lifetime limits as we see them. So we're going to just talk real briefly about the public exchanges, because a lot of this has really just hit the news in the last 3 to 4 weeks with the open enrollment starting. Public exchanges are in their 4th open enrollment, and they are hanging on for dear life. So if you look at, what officials, the CBO had originally estimated by 2016 they'd have 22 million people in the public exchanges, regardless of whether they're federally run or state run. But the enrollment in 2006 has really just tipped a little bit over 10 million. And I know you hear the number 20 million a lot, including from former candidate Hillary Clinton. The 20 million was with Medicaid. So the people that are actually enrolled on the exchanges is a little bit above 10 million right now. So significantly less than what they thought. And a lot of people think that's due to the very low tax implication of not buying insurance the first year, coupled with very high prices and low coverage options. So on the exchanges, if you look at the exchange offerings compared to what the employer market offers, it's significantly different. So on the public exchanges, the deductibles are on average double what they are in a consumer-directed health plan under an employer-sponsored coverage, and the cost is significantly higher. And we kind of knew that was going to happen, right, because of the bad risk and just, that pool of people were the uninsured, the people out on disability. A significant population of those people were early retirees between 55 and 65 before they're Medicare eligible. So that was a tough population to cover in the first place. And the insurance companies, mind you, are still trying to make a profit on those people. So that's where we kind of hit a roadblock. And the thing that's helping the exchanges get people is 85% of the people that enroll on the exchanges are getting tax subsidies for it. So if you look at what's happened this year, we've had significant change this year, right? So Aetna was pulled out of 11 states for 2017, and they remain in 4. So that was a pretty significant change. Humana pulled out of 8 states and remained in 11 states, so they're in second place in offerings across the country. United Healthcare really came out mid-summer and said this is just not a profitable line of business for us, and they pulled out of 31 states, and they only remain in 3. And then Anthem is the biggest concern, I think, for most, looking at the exchanges and the longevity of them, even going forward even if Trump didn't win the election. Anthem threatened to pull out of all of the exchanges in 2018, and they are in 14 states right now as the main offering, and in some of those 14, they're the only offering. So the cost is high, access and choice of providers is low, higher deductibles, higher out-of-pocket. Just in Pennsylvania, in my state, we had a 15% increase and we lost 5 carriers. The average increase on the exchanges is anywhere between 25 and in some states they got a 55% increase across the board. So it's definitely been a challenge to try to make those work. And I always, you know me, I always put a cartoon or 2 in there just to try to make my presentations a little less boring. $1,200 for 2 apps.
We're getting a little bit of feedback on the phone. If you want to there's a little bit of static maybe coming through if you want to double check, and I'm going to go ahead and mute everyone's line again really quick. Hold on.
Phone, it's *6 to mute your phone if you're on audio only.
Okay, sounds good. Thank you. Sorry to interrupt.
All right, and Kelly, did we want to do the first polling question now?
Absolutely. Here we go. Ladies and gentlemen, please feel free to vote in our poll right here at this time. Do you think the change in the administration will influence your healthcare strategy?
Interesting. So we have over 50% of the people answering the poll are stating that, yes, the change in administration is going to change their strategy. I don't doubt that at all. I think that if the excise tax goes away, that was really what was driving employers to control costs. But I will tell you that if you look at what's going on with just our cost and trend, you know, to effectively manage employer-sponsored health insurance going forward, consumer-directed health plans are definitely going to take over the #1 prevalent spot. So the transparency tools that we need to deploy are critical, and managing pharmacy. Pharmacy is the #1 concern on every survey I've seen of large employers, and large employers is any employer over 500 employees. So when you look at pharmacy specifically as something that's driving our strategy, I don't think employers are going to take their eye off the ball, but perhaps the change in worrying about the excise tax will maybe slow change down a little bit, hopefully, and really get into what we're going to talk to next, which is the power of data and kind of building your strategy and really understanding what data elements we need to target some of the things that we're trying to solve for. So some of the things that we're trying to solve for certainly are high claimants. Cancer's way up. Chronic conditions are driving our cost with now it's actually the new release from the CDC says over 50% of Americans have a chronic illness that they're either taking medication to manage or dealing with. And then, of course, specialty drugs are front and center as one of the biggest concerns. Interestingly, just statistically on specialty drugs in 2018 will be 50% of all drug spend. There's over 900 biologics in the pipeline under development today. And in 2015, pharmacy represented 26% of our total cost, and they're saying this year in 2017, coming up, pharmacy will actually outpace inpatient hospitalization costs. So that's pretty significant. It's going to definitely be something that we're going to want to focus on and manage significantly. Of course, the excise tax is definitely going to be a game changer, and you know, even if the excise tax stays in place, some of the changes proposed to it will significantly help us not have to, you know, really worry about that for 2020 in most cases. And large employers are looking at some different ideas on how to manage cost with some slick transparency tools and quality initiative indicators to help their employees find higher quality of care, lower costing solutions to care. So the ACO's implementation of the reference-based pricing. A lot of times people talk about reference-based pricing, and it is a little bit difficult to communicate that type of plan design to broad employee bases because you really, unless you have a finite number of pieces to the reference-based pricing, I'll tell you that the most common is MRIs, right? MRIs vary in one, you know, zip code from, you can have one MRI facility doing an MRI for $800, and if you go to a hospital setting or an inpatient hospitalization kind of setting for an MRI, it could be upwards of $3,000. So you really have to give your employees a lot of information in order to make a plan design like that work. And then, of course, carving out pharmacy to a PBM. So, you know, now it looks like for 2017, the number is between 40 and 45% of employers looking at carving out pharmacy and going directly to a PBM for a more focused approach in management and better pricing. So those are all strategies that folks are looking at. These are just simply, we're going to provide a copy of these slides at the end of the presentation. I think Kelly said she'd send those out tomorrow. So these are just anecdotal, you know, informational pieces on things that I get asked a lot. You know, what is the average cost? Employers are still paying 78% of the cost of health care for their employee. And I know things like that, little numbers like that are things that when you're looking at your plans and you're trying to benchmark where you want to be this year and next year, those are important to know. So I've provided those in here. Specialty drug, that last bullet point, is startling that it's going to increase to that degree. And we're paying for that, so we need to manage those. And then average out-of-pocket costs obviously are substantially going up, with 1 in 4 employees covered in a high deductible plan in 2015. It's much, much higher in 2016. And like I said, in 2017, 84% of large employers are going to offer a consumer-directed health plan, and 35% are going to offer it as the only option. Spousal surcharges are definitely growing. We're almost at 40%. The average surcharge is about $100 a month. We've seen some in 2017 move that up to $200 a month if the spouse has coverage elsewhere. And then if you take a look at the real problem, it's really poor health, and poor health of dependents and families is really lowering our productivity. It's costing us absence time. And for some businesses, such as hospitals and school districts, absenteeism is definitely something that is very, very concerning, and something that in the data analysis, if you can wrap in not only just looking at your medical claims and your pharmacy claims, but looking at your disability claims as well to kind of wrap those in and match those up and pair them up. There's a large correlation between absence management and some of the key indicators on the chronic illnesses. So in building our process, one of the things that we do is we look at everything by quarter. So in the first quarter, at the end, basically in February or March, if you're a January renewal, you're going to be exactly what we're going to talk about in a second, gathering your data. You're going to be pulling your data for calendar year end 2016 to look at what your key drivers are, your key cost items are, and how those key items are able to be managed within a strategy. So you're assessing your cost, you're looking at your key drivers, you're looking at your drug spend, you're looking at name brand generic, specialty utilization, and you're devising a strategy and saying, okay, with that data and with that knowledge, what levers can we pull in the plan design to change those trends? And then, of course, in the second quarter, you're doing RFPs and renewal management and vendor management through the summer. And then, of course, the financial management is really all year round. It's a quarterly dashboard that you should be looking at. And that's really important. So for those of you who really just look at the financials once a year, one of the things that I'd encourage you to do is try to take a look at things on a quarterly basis if you're not, and matching up budget to actual. And so if you're way off budget because you've had 3 or 4 high claimants this year, that would give you the opportunity to kind of get out in front of that renewal and really drive hard in the renewal process to make sure that your carriers are the right carriers, your pricing is the right pricing, and of course the disease management and the clinical management is where it needs to be. So those are the key elements of why we look at data. We need to put together a strong strategy, and today it's more important than ever to understand your data because you really can't build a strategy if you don't know what you're solving for. And it also gives you and your company management a roadmap of here's the next 3 years and here's what our strategy is. And then, of course, every year you're looking at that, tweaking it, really trying to make sure that you're in front of any issues or problems. I was with a client earlier this week, and we were talking about clinical management programs in pharmacy, and they had a significant renewal. I mean, they had such a good renewal. It was a minus 13%. I've never seen anything like it. They're running really well. And they said, MB, we don't have to worry about managing our specialty drugs because we don't have utilization in the specialty drug area. And I said, this is the perfect time to put clinical programs in because nobody's on them. It's harder to say to somebody, you can't have the drug you're on. It's easier to say to somebody, you got a new script, but you need to try, instead of PCSK9 at $1,000 a month to control your cholesterol, try the Lipitor, which is $100 a month to control your cholesterol. So it's a lot easier to put those clinical edits in place before you have a problem instead of, obviously making people change and influencing habits once people are already on a medication and it's working. So this is really a cheat sheet that I put together for everybody, and it's a cheat sheet because people ask me all the time, like, what are the things that we should be asking for? What are the things that we should be looking for? And these are the key indicators, right? So you want to know your enrollment by plan and by tier, and you want to know employee versus dependents. And that's key in understanding whether your dependents are spending the most and they're your high claimants or whether it's your employees, because that will dovetail into how you design your payroll contributions. Episodic analysis, looking at top diagnoses, disease state categories. I mean, this is the place where it gets really fun, right? This is the place where we dive into the data and you can really make a difference, right? So if you have, you look at your data and you see you have a significant number of diabetics, then you can say, okay, what's the adherence rate for my diabetics getting a retinal eye exam, and are they taking their maintenance medication on time? If they have a 90-day supply, what's the average refill rate? And if it's 145 days refill on a 90-day supply, you know they're not taking their medicine. So looking at this data and really ripping apart, understanding how your top drivers of your cost are really utilizing the plan and how we can help them is really exciting. So if you look at, you know, we talk about diabetics all the time, but if you look at your top categories, your top disease states, it really does play out over and over and over again that 90% of your dollars are spent by 10% of your people. So really, if you think about it, if you can, you know, really look at the data elements and look at your prevailing claim bucket and really get in front of that, that will help you reduce the 10% that are spending 90% of your dollars. So if you look at data, I look at data in 3 buckets, right? And we ask our carrier partners to give us data in 3 buckets. The buckets are your well bucket, the people who aren't using a lot of health care. That doesn't mean they're well, it just means they're not using a lot of health care. And then you have your middle bucket, which is your prevailing claims. That's the bucket you want to focus on, and your carrier should help you. And we're going to talk about what they need to provide you so that you can really get in front of those prevailing claims. Those are the people that are early diagnosis or have key indicators of a diagnosis that might be a large claimant. Your large claimant bucket, you want to manage, that's the 3rd bucket. You want to manage those people, but they're already large claimants. So there's, you know, you manage them to the best of your ability. You try to give them the most help you can. Certainly, anybody who's going through a transplant or cancer treatment, you want to make sure that they're in the right setting and getting the right care at the right cost. But the chronic illness bucket, the middle bucket, is where we spend most of our time in trying to really understand the episodic disease categories and how those people are caring for themselves. And I think I'm going to pause there. Kelly, did you want to do the second poll?
Absolutely. Again, ladies and gentlemen, just like before, we have a poll. Please participate. Just asking if you think that you currently receive the data that you need from your carriers.
Kelly, I don't see the poll.
Well, maybe give it a second, Mary Beth. We've got some other people that see it. They're voting. 70%.
I don't see them. I don't see the poll, so you'll have to read me what the results are.
Well, we've got 70% of the audience saying that yes, they get the data that they need. 4% say they do not get what they need, or that they don't know if they get what they need. And then 26% say no, they do not get the data they need.
Okay, well that's great that many think that they are getting the data that they need, because that's important. That's important in building the strategy. So the strategy planning really is taking those reports and looking at state of the market, you know, how you fall in geographically and in your business, benchmarking to make sure that your plans benchmark where you want to be. And there's some companies that want to benchmark at the 90 percentile. They want to be way out in front and cover more than what their competitors cover. And then there's some companies that potentially might not, you know, place a high value on their benefits offering that want to benchmark at the 50th percentile. So wherever you want to be philosophically, it's interesting to take a look at those benchmarkings and really assess where you are plan design-wise versus your peers and your geography. And then, of course, you know, the plan management options, you really creating a philosophy around benefits where you have buy-in from management is important. And then the financial modeling and the tools that we're going to talk about in a second. So this is a sample of a strategic forecast tool. And again, I would encourage you, if you're not looking at things in more than 2 to 3 years, you should take a look at your costs. This is a 5-year snapshot because I think this is how you get people's attention, right? So if you're building a strategy and you're trying to communicate, let's face it, our job in HR is very difficult because we're trying to communicate with the C-suite why this is important and why this is important to manage and get out in front of and really look at these opportunities to make plan design changes now. Because if you look at your cost on a 2016 and you run it out 5 years, you can see the significant, just with normal trend, the significant cost increase. And then, of course, you look at your opportunities and the opportunity pyramid there. It's kind of a little bit hard to see, but when you get the hard copies of the slides, you'll be able to look and see, the consumerism, health management initiatives, the contributions that you have set up, the plan designs, and really making sure that your plan designs based on your data is pushing people in the direction that you want to push them. I will tell you to just kind of take a step back and do a little talking a little bit about how the consumer-directed health plans have helped us. They got off to a slow start because I think initially companies, employers that value their benefits really were uncomfortable with a high deductible plan. And I heard from a lot of CEOs and CFOs that they were concerned about putting a high deductible plan in because they didn't think that people had $1,500 or $1,500 in their savings to cover that deductible before they got coverage. And when you explain to them, you can put an HSA in place. You can make it an option to a PPO. And just the psychology around how those have helped us mitigate trend and costs. When you have an HSA and you give somebody $800 in their HSA towards that large deductible and you get pretty close to the PPO deductible, it's amazing how the buying experience for the employee changes, right? So you have employees that now have, even though it's employer money put into their HSA, that HSA is their account, right? They can take it if they leave. They can save up money and use that towards expenses when they retire, potentially. It's a tax advantage for them to put money in that HSA, and they spend it more fiduciarily. They really, when they're going to the pharmacy, statistically, when they have a high deductible plan with an HSA, people are saying, that's a very expensive name brand drug. Is there a generic option for me? And those are the questions that we've never seen before. And that's very encouraging because we want people to behave, and how they're spending healthcare dollars in the most conservative way possible if they can. So the financial management, I talked a little bit about your quarterly dashboards. You really want to look at data on a quarterly basis because things can significantly change. You want to be looking at high claimants in smaller buckets. So if you have stop loss at 100,000, you want to start looking at claims when they get to 50,000 typically, or it's typically 50% of whatever your stop loss is. I really like to look at anything significant over 25,000 because that's usually headed in a large claim area, anybody that spends that combined pharmacy and medical. And then taking a look at your metrics and really budget to actual metrics to make sure that you're on task and you're on plan for meeting those goals and objectives. And then, of course, here's a sample dashboard. We do these sample dashboards because we like to look at last year compared to this year. And if you look at that bottom line, that bottom graph is a 36-month look back where we can see, here's where we were, here's where we're going, and those spikes are usually just high claimants that are driving our cost up. But you can see the medical trend over a longer period of time, which is a better indicator, I think, in predicting the future. So you're looking at the number of enrollees. if you're in a business where you have a fluctuation of headcount, this executive dashboard, I think, would be critical for you on a quarterly basis, just to make sure that you were, from a budget perspective, protecting yourself from the headcount fluctuation in cost. And then here's another report that, again, if you're working with your carriers, so there's really two avenues of data management and data warehousing, as they call it. Most companies use their carriers to get their data, right? So if you're self-funded, your TPA or your carrier is providing you your quarterly utilization reports and your year-end reports. And if you go back to that cheat sheet, they should be getting you everything on that cheat sheet on a quarterly basis. And then if you look at those utilization reports on a quarterly basis, you should be able to tell your total claims, what they're projected to be on an annual basis, and really understand the chronic disease risk. So really looking at, what are your top diagnoses, what are your top 20 drugs, really looking at that drug list, the top 20 drugs, and working with the carrier or the PBM to understand what drugs are driving your cost, and are any of those drugs coming off patent in the near future where there are generic opportunities, clinical programs where there's more than one medication in one category, that maybe you can create a formulary where you're pushing people to lower costing medications but within the same category of drug. So these key indicators and the data analysis is really important. I mean, if you have a high number of asthmatics, a high number of diabetics, those are absolutely diagnoses and illnesses, chronic illnesses, that you can put all kinds of great plan designs in place in your strategy to help those people manage their disabilities or their illnesses in the most cost-effective way. So the goal and objective with the data management, in my opinion, is not just cutting costs, but it's really looking at who are the sickest people in your population and how can we help them, and how can we help them get well, and how can we help them get better care. So that goes hand in hand, and that will lower your cost if those people are taking their medications on time. In years past, it's really interesting, because in years past we thought 5 years ago that people weren't taking their medications, especially maintenance medications, because the copay may have been cost prohibitive. And what we found statistically is you can make maintenance medication free and you're still going to have an adherence problem, because it's really not all about cost, it's actually access. So telemedicine, some of the new tools that have been rolled out in the strategies of late, over 25 to 30% are using telemedicine or a tool like that, because it's really the access that's the problem, right? So we have two working parents in most families. We have, just tons of stuff on our plate, both at work and at home. And statistically, when you ask people why they're not adherent with their maintenance medication, it's because they haven't had time to get to the doctor and they haven't had time to get to the pharmacy for a refill. So the telemedicines and some of those other opportunities in the strategy have really moved us forward in helping people get their medication and taking it on time. This next graph is a great graph, and they look different by carrier, so this is just one example of it. But you should be getting these, the chronic disease opportunity, whether it's in a pie chart or whether it's just statistical numbers. You should know, how many cancers, what your acute care diagnoses are, what are the most prevalent ones in your population. And it's interesting because cancer is always huge. It's been a driver going forward, and I don't think it's going to go away. We see the same things. Depression is always in the top diagnoses. Skin cancer was up this year in a bunch of clients where we took a look at the data. And when you look at those disease and chronic illnesses, that really helps you build your strategy, right? So if you have a large population of people with cancer, there are voluntary benefits that you can put in place. There are some very big concerns with cancer with the medications going through the medical plans. So for oncology drugs, the specialty drugs, oncology is probably the number 1, 2, or 3 category that you're going to see on your utilization under the pharmacy. And if you're just looking at pharmacy and PBM claims and you're not looking at the pharmacy that's running through the medical plan, you're missing half. So half of your specialty drugs right now are running through your medical plan. They're not going through your pharmacy plan. And that's a key thing to take a look at when you're doing the data analysis, because those J codes is what they're called. If you don't pull those and look at them under the medical plan, you're going to miss a lot of the oncology drugs because those are administered in the doctor's office and those get put through under the medical claims and they don't go through the pharmacy plan. So you're not getting rebates on them, you're not getting discounts, and it's something that's a major concern because cancer is so prevalent today, and looking at that as one of the data elements that you need to be aware of. And then, we use the stoplight approach because it's easy to understand, but we look at, each disease category. So once you've identified what are your top 10 disease categories that are driving your utilization, you can see compliance, you can see cost, you can see how you benchmark. There's a lot of different ways that you can benchmark by disease category how well you're managing those diseases, and then those are obviously anything red where you're not managing them as well as you can be, really taking a focus in the strategy. And when you're building your strategy saying, these are the top 5, we're going to pick off the top 5 this year, and we're going to put programs in place, disease management programs. There's clinical programs that are freestanding now with so many companies that have come out with new opportunities in the last 2 to 3 years. I mean, there's even technology now with smartphones that are sending reminders to people when they're supposed to be taking their maintenance medication. Diabetics are usually, I think the number that I heard was 75 to 80% of diabetics wear glasses or use contact lenses. And now there's new technology where these contact lenses are measuring their glucose levels and sending them messages to their watch when they're getting low. So we really need to embrace some of the new technology, including the telemedicine opportunities, in our strategy for next year. If you haven't looked at those, definitely are bringing us a little bit further and helping people manage their conditions. So that kind of wraps up my presentation. We have about 10 minutes left in the hour for questions and answers. And Kelly, I don't know if you have gotten some questions during the time of the presentation, but we'd be happy to answer those and take questions now.
We have gotten a couple. One that just came in was, how often should your carrier provide you with those reports?
It really depends on the size of your group. I like to see them quarterly. We provide them for our clients quarterly, and it's really just a dashboard. It's rolling up budget to actual. It's looking at high claimants. It's looking at pharmacy and what if you're halfway through the year and you're at 80% of your budget, you're not running well. And that would give you an opportunity to take a look at, what's running hot and what can we do, in essence, in the last 6 months of the year to influence that inevitable large increase at the end of the year. I look at it quarterly because I just don't like to wait too long if something's going awry to make some plan tweaks, adjustments. And again, it's not in plan design that you would need to communicate to the employee. It might be in the vendor management or how the PBM is managing the pharmacy, clinical step edits that you can put in place. One of the things that we did, with a lot of clients last year mid-year, because we saw some of those specialty drugs impacting our clients, is putting, grandfathering the people who are already on the most expensive drugs, but putting clinical step edit programs in place so that new prescriptions for those extraordinarily expensive drugs, they had to try something that was on the less expensive list in that category before they jumped to the most expensive drug. And that helped halfway through the year, really helped some of our clients mitigate a bigger increase, I think, if they didn't do that. Anything else, Cal?
How about this one came in? How large of an employer do you have to be to use a data warehousing tool?
That's a great question. So it really runs the gamut. We start out with our new clients with the first year using the carrier reports. So the carriers, your partners, the TPAs, they have all your data. We usually start with what is it that you can provide, and are we going to be able to use that data and get everything we need from the carrier? If you're finding that you can't get the data that you need, or there's a large hole in what you're getting to fulfilling the big picture, then there's certainly freestanding tools that you can buy. So we have a data analytics unit that we sell as part of our consulting package for companies that don't get everything that they need, or companies that have multiple carriers and want one source for the data. So if you're, let's say you're 5,000 employees and you have 2 different carriers because you're in multiple states, we can provide you with a data warehousing tool through Verisk, who's our partner. Optum does it through UHC. So there's various companies out there where we can kind of warehouse the data, take it in from multiple sources, and then present our clients with a cohesive data report and package so that we can do the strategic planning. And it's not a matter of size, it's a matter of cost. So depending on what it is that we're looking for, cost for a data warehouser can range from $25,000 to $100,000 a year. But I will tell you, if you're not getting the data that you need and you're not building a strategic plan, it really is worth the money to invest in trying to get a hold of your data, because you really can't solve for problems unless you know what they are.
Okay, excellent. Well, thank you, Mary Beth, so much. We don't have any other questions at this time, but we so appreciate your presentation, and thank you, audience, for joining us today for this webinar. Please do feel free to check out our website. Registration is open for 2017. You can see Mary Beth live at any one of the 2017 programs, or specifically in Phoenix, where she'll be doing the opening keynote presentation. As soon as we end the meeting, please take a moment to complete the brief survey that's going to open on your screen. And with that, thank you all, and I hope everyone has a great afternoon. We'll send you the HRCI and SHRM credit information along with the recording and the slides via email tomorrow.
Thanks so much, Kelly. I really appreciate it.
Great job.
My pleasure.
Thank you. Bye-bye.
Thanks.